Good afternoon, everyone, and welcome to Grand Rounds. My name is Tom Forden, I'm the chair and organizer of Grand Rounds, and I am today at an away day, which is a nice change from usual practice. So rather than being in my office, I'm in the Invercarse Hotel at one of the first away days I've been to in the living with COVID world. So it's really quite nice to be out here. But Grand Rounds continues. So I'm very pleased to introduce stalwart of the Grand Round scene and my good friend John Irving, who is a cardiologist here in Ninewells, and he and I have known each other for, well, a good 10 years plus professionally, and then I had the privilege of doing the ARCHIE mountain challenge with John 6 years ago, and we spent a good number of hours traipsing over many Munros, or I should say ARCHIEs, sharing war stories and sharing peanut M&Ms. So I'm always delighted when John emails to say that he'd like to do another Grand Round. And this is his third year in a row. These talks are always interesting. Cardiology is something, as a chest physician, we interact a lot inside the chest cavity. So we have a lot of dialogue. I'm always fascinated by what John has to say. And his talk is called Troponin, What's It All About? They will not be quite so straightforward as just telling us what troponin actually is all about. I think he's going to talk about about what does it all mean. And I look forward to listening to the talk. I have to go because my away day continues, but I'll be watching this back on the video, which I'll upload to YouTube when I have time. If you have questions, please put them in the chat, and John will take them at the end. John, thank you so much. Look forward to hearing your talk, but maybe just a bit later on. Thanks very much.
Okay, thanks, Tom. That introduction covers things quite nicely. What's it all about? We've had troponin for nearly 20 years, and we're not yet collectively excellent at interpretation. So here's a quote from an American colleague. When we weren't very good at measuring troponin, it was a great test, but now we can measure it very precisely. It's getting to be a lousy test. And that was in 2010, when assays had been available for 10 years. And they've become more sensitive since then. And we still have the opportunity to misinterpret things. And here's a recent case from Ninewells Hospital. This is the ECG of a patient who was in the cardiology ward. He had a little bit of chest discomfort. He had some subtly abnormal T waves in the lateral leads, and a troponin was checked and it was elevated, and he was treated with anticoagulation and strong antiplatelet agents. His chest x-ray was relatively normal, but his chest x-ray a few days prior had shown an ICD that had been removed because it was infected. His ECG always had T-wave inversion, and his mild chest discomfort was due to the discomfort of having an ICD removed. And when an ICD is removed, there's a lot of adhesions between the leads in the thin-walled structures of the superior vena cava and the veins, and bleeding is a significant risk, and obviously enhanced by anticoagulation. This was a perfect mistake because there were absolutely no consequences for it. I've been a doctor for nearly 30 years. I'm very familiar with medical error, most of them my own. If the person who was doing that, who was looking after the patient that night is here, I really don't want them to feel these sort of emotions that we often feel when things have not gone as we'd hoped, and sometimes it's very easy when we discuss difficult cases to feel these emotions. And of course, there's reasons and there's biases in our thinking that stop us from necessarily getting to the correct answer. And in this case, there was authority bias. It's generally a good course of action to do what the nurses in cardiology tell you to do. But it wasn't in this case. And there's bias towards action, that we feel that we have to do something in the face of changed information. And these biases are lead us to incorrectly interpret the guidelines for managing patients with suspected ischemia. So there's you can find lots and lots of these very, very complex diagrams, and we have one that colleagues in Perth produced, and it's a fantastic effort. It requires a huge amount of time and careful thought to get everything down on one page about how to look after patients with the tests that we have and the treatments that we have. And at the top of the guideline, it refers to clinical gestalt of the senior decision maker, and that's correct. But that's the problem with the complexity of these sorts of documents. That if you start down the wrong track, once you're on rails down the wrong track, you're not really assisted in getting back to the correct course of action. So how can we avoid the fact that bias promotes error sometimes? Well, perhaps if we have a detailed understanding of the diagnostic categories that we're trying to use for the patient, if we're trying to make an accurate patient assessment. I apologize, I've got poor Wi-Fi in my office, so I'm squatting. Right. If we can make if we have a detailed understanding of the diagnostic categories that we're trying to fit a patient in, then we can make a very accurate patient assessment. And if we feel secure in our capacity and in our role of seeing wood from the trees, then we can potentially get it right more often. So troponin, what's it all about, or just what is a heart attack these days? Here's an angiogram of a patient having a heart attack. This is the guide catheter that we've floated up from the radial artery. We've inserted to the left main stem. We've injected contrast. The left anterior descending artery, which should continue all the way around to the apex, is blocked here in its mid portion. We've fed a wire down, and in this case, we aspirated quite a lot of thrombus out of the coronary artery. The thrombus had been occluding the vessel. At this point, the thrombus had propagated from the plaque rupture here, which you see as a narrowing. So the contrast is outlining the artery, and it's severely narrowed here as a result of a rupture of an atherosclerotic plaque. And then we put a stent in, and we fixed the problem for this patient. So that patient was having a heart attack. But what is a heart attack depends on the filters that we use. So I'm going to talk a bit about the ECG definitions of a heart attack and how they were derived. And then I'm going to move on to the troponin-based definitions and the more recent universal definition of myocardial infarction, and informed to some extent by the results from coronary angiography and intravascular imaging, although I'm not going to share a huge amount of that. So this is the results slide from ISIS-2. This was an absolutely transforming study coordinated in Oxford, a randomized control trial, which confirmed the results of meta-analyses. There had been about 30 studies in the preceding years, 60s and 70s, very small studies of using thrombolysis in acute myocardial infarction. And a meta-analysis showed that it was likely to be effective in saving lives. But it wasn't universally accepted because thrombolysis has risks. You're going to cause a small but not zero rate of severe strokes from hemorrhagic stroke, and you may cause life-threatening bleeding. And patients who were at high risk tended not to receive thrombolysis because people were scared of the consequences of the treatment. This trial was double-blind. Patients were randomized to streptokinase and aspirin, either of those agents or neither. And in follow-up, people who had the best survival if they were given both. And the differences in survival were profound. So 13% death rate, vascular death rate had emerged by about 1 month after treatment, versus 8% in patients who had aspirin and streptokinase. And these differences were maintained out to 10 years. So that if there was no late catch-up from the patients who'd been treated actively. It transformed the landscape in trials, so that mega trials were done. Unfortunately, the pragmatic approach that the data could be collected on one side of a piece of paper, and the pragmatic inclusion criteria that the doctors who were looking after the patients needed only to be uncertain as to whether streptokinase and aspirin would be helpful for treatment. And that meant that everybody was recruited, and that meant that there was huge power to demonstrate very important differences. There was some power to demonstrate important differences in subgroups, most famously in terms of the astrological sign dictating aspirin non-responsiveness, and giving a very vivid illustration into the potential for subgroup analysis to mislead. We always think of myocardial infarction as ST elevation myocardial infarction for thrombolysis, but because there was no specific ECG criteria mandated for inclusion, there were actually quite substantial numbers of patients who we no longer think benefit from thrombolysis. So patients who didn't have ST elevation but only had pathological Q waves, and then patients who we would now call non-STEMI, T wave inversion ST depression. And following a meta-analysis of all the thrombolysis trials that were put together in the early 90s in the Lancet, the concept emerged and has really stuck of ST elevation myocardial infarction. So here, relatively subtle but distinct inferior ST elevation with associated ST depression in the other leads on the opposite side of the heart. So somebody that has a thrombolysis sensitive acute coronary occlusion, and versus the non-STEMI, so widespread ST segment depression. Yes, there's ST elevation in AVR, but that's what we often see with this. So this is an ECG definition of subtypes of myocardial infarction. We know that with acute coronary occlusion, we know from our intravascular imaging, we know from pathological studies that there's various things that can happen in your coronary arteries that lead to acute occlusion. Rupture of plaque over often a thin capped vulnerable plaque that's got a very high lipid content, and the fibrous cap may rupture completely, exposing this highly thrombogenic structures to the blood. So if the clot occludes it, it may be eroded, and clot may form and dissolve, and clot may form and dissolve. There may be calcified nodules, which can be the nidus for thrombus formation. We may see an embolus. We see that from time to time, and the coronaries are otherwise normal. We may see spontaneous coronary artery dissection, which when I was a registrar was considered so rare that a single case was worthy of a case report, but it's now recognized to be perhaps 2% of myocardial infarctions now that we're doing angiography routinely. Profound coronary spasm may cause ST segment elevation. And thrombolysis was absolutely key breakthrough in terms of improving prognosis, but subsequent to thrombolysis trials, the randomized trials of thrombolysis versus immediate angioplasty were collated in the Lancet in 2003, showing improved reduced risk of death, reduced risk of stroke with angioplasty, important risk of huge reduction in recurrent ischemia in hospital, and all of these risks were also reduced in the longer term as well, such that primary angioplasty is clearly superior to thrombolysis, and the system works now that the patients are in the care of the paramedics. They telemeter the ECG to coronary care, where it's interpreted by experienced nurses who activate the lab, and that means that very few people actually see people having a STEMI these days, because the paramedics wrap them up in a blanket. We wrap them up in the in the drapes and just get on and stent the artery. And that means that very few people see what a STEMI is actually like. And the reason that we do all this so quickly and that we bypass the medical receiving unit and we bypass the emergency department is because of the importance of time. So when we look at these studies, which are observational from an experienced center in the States, if you've got low-risk patients, then the long-term cardiac survival is pretty good. And there's not a particular change if the patient is delayed. However, when you look at high risk, you can see that patients who are looked after the quickest have the best survival, and patients who take more than 3 hours from the door to get into the catheter and have a balloon, the difference in cardiac survival, so death from a cardiac cause, is 15–20%. The difference in survival between 1.5 hours and 3 hours is very similar to some of the potential transfer times or difficulties in getting out of a different unit. The survival curves, this is not randomized data, nobody's ever been randomized to delay or no delay, but the survival curves are pretty much parallel, implying that the patients who've had the delay would have had the same survival had they not had the delay. In this study, high risk was defined by the presence of heart failure, being more than 70 or an anterior infarction, but this is more than half of the population. So immediate treatment is important in a STEMI, and it works well. I'm very fond of this slide. I was on call for primary angioplasty when I was doing parkrun that Saturday morning. I'm holding my mobile phone in one hand, looking slightly worried because I'm about to be overtaken by this chap who'd already had one primary angioplasty. And he's happy to share this photo as well, because he's considerably older than me and just overtook me without appearing to me to have to try. So, non-STEMI, patients presenting with a heart attack with different ECG changes is a spectrum. And many of them will have acute coronary syndrome. Many of them will have plaque ruptures, as I showed on that illustration a few slides ago. Plaque rupture is remarkably prevalent. So big study done in the 80s showed that you might have minor plaque rupture in middle-aged men who've died of accidental causes. And it almost always heals up, but when it doesn't heal up, it causes a big accumulation of thrombus and acute vessel occlusion. But it may also be seen in bystander coronary disease. So I will show you some more angiograms to illustrate that. So this patient came in on a Friday afternoon. She's got a chronic occlusion of her right coronary artery, and she's got a hazy left main stem here. So the left main stem should be much bigger than the caliber of the LED and the circumflex. So all of the blood going to her heart is trying to squeeze through this narrowed segment. There's clot there, probably on the basis of a calcified nodule, but she's got profound ECG ischemia. She almost certainly wouldn't benefit from thrombolysis because there's severe atheroma and there's calcified nodules. So while there might be a little bit of reduction in thrombus there, it's not going to deal with the underlying cause the way that a stent did. This patient also had no ST elevation on their ECG, and the culprit lesion has been a conclusion of a big branch of the circumflex. And sometimes these have no ECG changes at all. Now, arguably, the pathology is exactly the same as many of the cases of acute vessel occlusion that does benefit from thrombolysis. But the patients in the trials given thrombolysis, some of them would have a situation that would be amenable to lysis, but many of them would have situations that would be no particular benefit and only harm. And that's partly because you get a lot of patients like this. So this patient's right coronary artery is occluded at this point, but this branch is giving rise to many of the collaterals to the LAD, which is then giving rise to many of the collaterals to the distal right coronary artery, the circumflex. Many of the branches were also occluded. So this patient had a very perilous and interdependent coronary circulation. So when he became unwell for relatively minor reasons, he became profoundly unwell because of profound ischemia. And thrombolysis in his case would have achieved nothing because the occlusions were chronic. And then you have patients who present with pain and pancreatitis and ST depression. We've seen a diabetic patient who had cholecystitis with profound ST depression. Sometimes atrial flutter alone will lead to ST segment depression. And there's nothing happening acutely in the coronaries to cause the ECG changes. And the patient may or may not benefit and may or may not be harmed by anticoagulation. So with the advent of troponin, a very sensitive, and very specific biomarker of myocardial damage, we now think of myocardial infarction as different subtypes. We've talked mostly about coronary plaque rupture leading to type 1, which might be STEMI or non-STEMI, depending on the location of the plaque, depending on the severity of the coronary disease. But the most important concept for clinicians is the difference between coronary plaque rupture that benefit from anticoagulation and antiplatelets and a type 2 myocardial infarction, which is due to ischemia, is caused by ischemia due to excessive myocardial oxygen demand or inadequate supply. Sudden death is more concerned to pathologists, and the type 4, type 5 are associated with PCI and CABG and are moderately useful concepts. So in type 1 myocardial infarction, so high sensitivity troponin, this, and many of the slides that I'm going to use come from the very active, very expert group in Edinburgh that have published very widely and extensively and improved our understanding of what troponin means. So patients with suspected acute coronary syndrome, so we're thinking that they have type 1 myocardial infarction. If you have troponin at extremely low levels in your blood, then your risk of myocardial infarction, type 1 myocardial infarction, or cardiac death is extremely low. It accumulates if you're above a low threshold, but if it's not detected or it's below the 99th percentile, then your risk is low and sustained low. And it is therefore a very useful test in identifying patients at low risk. It's good in most subgroups. The only people that you have to be concerned about are if it's relatively recent from the onset of the chest pain, or they've got a very abnormal ECG. In those cases, then there's a higher incidence, statistically detectable higher incidence of events during follow-up. But generally, these are clinically obvious. So we thought about troponin as a marker of, or the absence of troponin as a marker of low risk in type 1 myocardial infarction. What are the criteria for a type 2 MI? And this is the current definition according to the universal definition. So you have to detect troponin rising or falling with one value above the lab's 99th centile due to imbalance between myocardial oxygen supply and demand, unrelated to an acute change in the vessel, and requiring at least one of the following, which are not specific. So symptoms of acute myocardial ischemia, that doesn't mean that you have to have typical angina. You may have any ECG changes. You may have new development or subsequent development of pathological Q waves, or you may see a problem on echo or MRI implying a new myocardial infarction. So these are the criteria, but they're not specific. They don't help us say, well, is this definitely type 2 MI? What patients get type 2 MI? And that's all about context. It's about other illnesses going on in the presence of potentially abnormal coronary arteries, potentially abnormal coronary microvascular left ventricular hypertrophy, and these various abnormalities. And this is an important point. This thresholds for achieving a type 2 MI will vary substantially in relationship to how sick you are with the other illness or the extent of the underlying cardiac disease. And that's important. There is, of course, also people who have chronically elevated troponin in the blood, typically patients with renal failure. And I'm not really going to talk about that, because in general, we shouldn't be measuring troponin as a test for patients who've got no acute illness. So type 2 MIs, it doesn't mean that there's nothing wrong with the coronaries. So here's where the definitions are blurred, because a patient with a spontaneous coronary artery dissection has an acute coronary problem, but it's not an atherosclerotic acute coronary syndrome. So this is therefore defined as a type 2 MI. The patient may have developed a spontaneous or iatrogenic, a spontaneous intramural hematoma. They may have profound spasm, they may have an embolism. All of these patients are likely to present to cardiology with acute acute ischemic chest pain, and acutely unwell, and not be subtle, and not be difficult to differentiate, and not be difficult to determine that this is something for cardiology to sort out. But it's in the category of type 2 MI, which blurs the lines, which makes it difficult to understand what it is that we're talking about when we're thinking about type 2 MI. But it's there, it's an official part of the definition, and it's where I have to be critical of cardiology as a specialty in terms of trying to help everybody understand what it is that we mean when we think about type 2 MI. This is a much more useful illustration, because it illustrates the concepts of the reduced oxygen supply, and there's potential causes for that, increases oxygen demand, and there's potential causes for that, and then there's physiological mechanisms, or there's consequences that lead to physiological mechanisms that will tend to potentially worsen the mismatch between oxygen supply and demand, and worsen the ischemia, leading to infarction of myocardium. And all of this is going to be much worse the further you are along the spectrum of developing atherosclerosis in your coronary arteries. So with normal coronaries, you have to try pretty hard with these things to achieve a troponin release. And as time accumulates and atherosclerosis accumulates, then these stimuli may be less severe, leading to troponin release. And I think this diagram is yes, it's a bit complex, but it is potentially helpful. Now, here's a nice illustration of what we mean. This is from a paper in the British Journal of Anaesthesia. These are two stills from angiograms of the right coronary artery that have got lesions in them. This patient had not had surgery. The narrow bit here on the OCT, so OCT is a laser swept imaging. You put a catheter down the coronary artery, you get these beautifully clear pictures. There's a narrow bit here as we look at it in longitudinal section, and then when we look at the cross-sectional imaging, there's this homogeneous blob of thrombus, and you can see little fragments of it. This is a coronary thrombosis. You can't see the underlying disease because the plaque's in the way. This narrowing here, you can see that there's a lot of calcium. This sort of appearances in the wall here, very hard-edged, are caused by extensive calcification. So this patient's had a perioperative MI due to increased oxygen demand. This patient's had a plaque rupture and has got thrombus in their coronaries. And this was a relatively small study, so 30 patients in each group, but they were able to show important differences in terms of the proportion of patients. So this is percentages, higher proportion who had a non-operative MI, and a much higher proportion in this perioperative MI who had an intact fibrotic cap detected on OCT, and a much lower proportion having plaque rupture compared to the non-operative MIs. So while you might have a plaque rupture in a perioperative patient, and we have certainly seen that and managed that from time to time, it's much more likely to be a type 2 MI caused by imbalance. Who else gets type 2 MI? Patients with bad COPD, patients with heart failure. And yes, again, these sort of illnesses might lead to plaque rupture, but it's much more likely that that they've not had a plaque rupture. They've had profound ischemia leading to troponin release as a result of the severity of their illness in conjunction with a degree of coronary disease. What symptoms do you have? Well, it's not specific. You can't say symptoms of a type 2 MI are X, Y, and Z. The symptoms of the type 2 MI are due to the underlying illness that they have. There may be some ischemic pain. There's much more likely to be severe breathlessness. Not necessarily because it's an angina equivalent, but more because they're breathless because they've got pulmonary edema or they've got bad COPD. And the symptoms of ischemia are relatively silent. I think some of the difficulty that we have in the idea that myocardial infarction has protein manifestations, particularly that you will read regularly that women have atypical symptoms with myocardial infarction, and that's not the case. So here's again from Edinburgh, their big high stakes trial. So this plot indicates the symptoms that the patient reported and the severity and the description and what proportion of patients reported that. So they chose traditional gender colors. So men are in blue and women were in red. And actually women had more typical symptoms, were more likely to report typical symptoms in patients with acute myocardial infarction than men. And in patients who had suspected chest pain that proved not to be due to suspected type 1 myocardial infarction, there was no difference. So it's a long-lived meme that women report atypical chest pain, but it's not actually accurate. This was quite a big study, nearly 2,000 patients. Okay, can a type 2 MI become a type 1? Can 2 become 1? So another trial from Edinburgh, patients with type 2 MI, after 5 years, nearly 2/3 are dead. Much worse prognosis than type 1 MI. A proportion of that, yes, is a vascular death, but a low proportion of that is a fatal MI, and a much higher proportion is non-cardiovascular death. So having a type 2 MI when you're confident about it, yes, because when you do studies of elderly people in Scotland who've been ill with heart failure or COPD, their prognosis is their long-term life expectancy is poor. But actually, type 1 myocardial infarction isn't a particularly strong part of that risk factor profile. And here's this similar information showing much better survival with type 1 MI because these patients are younger, and we've got a lot of very effective tools for treating acute coronary disease. And patients with myocardial injury who've got troponin for other causes, but not fulfilled criteria for type 2 MI, or patients with type 2 MI are much older and more likely to die. And that shows things in a different way. So if you've got if you've got known coronary disease, yes, your risk of cardiac events is higher than if you don't have coronary disease when you have type 2 MI. And yes, it's possible that some of that may, to some extent, be modifiable more than the risk of non-cardiovascular death is. But the patients had quite good or reasonable risk factor control. So angiotensin receptor blocker, yes, it's not as high in patients with type 2 MI with known coronary disease. Statin prescriptions not quite as high. So it's plausible that treating these patients with coronary disease might improve the risk factors a little, but it's not a huge risk. It's not likely to be a huge gain in the long run. So how are we doing for time? Troponin, what's it all about? Well, it's about the history. Why is it in the blood? Is something happening in the coronary? Well, then the cardiologists are definitely going to be interested, and the patient is likely to benefit from antiplatelet drugs and anticoagulation. Or is something happening somewhere else, in which case anticoagulating them and giving them strong antiplatelet drugs is unlikely to help them acutely and will confer some degree of risk. I think we've not. I think STEMI is quite a vivid diagnosis. People have got good ideas about what a STEMI is. It's a middle-aged man clutching his chest, slightly older woman clutching her chest, but we don't have the vivid picture of a type 2 MI because it's very heterogeneous. It might present very analogous to a STEMI. You might well have a STEMI with a type 2 MI, and that's confusing because actually the real hazard of type 2 MI, or the iatrogenic hazard, is anticoagulating people or putting them through invasive investigations like angiography when they don't need it. And I think when it comes to understanding diagnostic categories, it really helps if there's a prototype. If it's clear what prototype's the wrong word, but if it's clear, you can think about it and you can picture the patient, the typical patient who looks like reports symptoms or has underlying conditions that make it likely they have a type 2 MI. Now, in terms of fun, type 1 fun is fun that's fun at the time. Type 2 fun in the hills is fun that may be fun in retrospect, but is not fun at the time. And that's almost analogous to the difference between type 1 and type 2 MI. I think type 2 fun has become sufficiently vivid that the type 1, type 2 definition is helpful and people know what they mean. But I think we do have to do better when it comes to finding a name for type 2 MI, or finding a way to illustrate it that people will find vivid. And these are not my serious suggestions, but you could have, instead of a STEMI, you could have a STEMI, which stands for Sardonic Cardiologist Hating Troponin Elevation Mandating Interpretation, because I'm conscious that I can, and my colleagues can sometimes be a bit grumpy when we're asked to sort out what the troponin means. We've had it for 20 years. We should all be good at it. Now this is very Scott specific. NAFUL associated troponin. I'm not proposing these as serious diagnoses, but it may be that we could find a way of making the type 2 MI more vivid for people to feel confident about diagnosing it and recognizing it. So here are the pragmatic guidelines that I'd like people to think about. If you think the patient has coronary thrombosis and they're having a STEMI, well, they're going to go to the lab, and CCU will help you out with that. If they have a non-STEMI on their ECG, then they do need treatment. Obviously, these are patients with chest pain without anything else going on. They do need treatment. Aspirin, I've shown you the data as to how effective aspirin is in STEMI. It is effective in non-STEMI. We've spent a long time in cardiology debating about the different possibilities of more potent antiplatelet therapy. I think clopidogrel, given early, is fine. And it's more important that a patient who has a coronary thrombosis or a plaque rupture is treated with 2 antiplatelet therapies. The recent European guidelines discourage this because they think you should be in the lab early and then you should have prasugrel. That's fine, but that doesn't apply to the current system. It's just not possible in the NHS in general, in Tayside in particular, to get patients with non-STEMIs into the lab reliably within 24 hours. And I think if you're picking patients who've got plaque rupture, they're likely to benefit. And if you give them clopidogrel, I'm much happier with that than not giving anything. Yes, if you're confident that you think that the ischemic risk is high and the bleeding risk is low, sorry, that dash is in the wrong place, then yeah, I'm very happy if you give that. Arguably, it's better because it wears off sooner. But in elderly patients, clopidogrel did better. I think fondaparinux is important because that looks after the clot in a synergistic way. I think beta blockers are important. The original ISIS trial was in STEMI or acute myocardial infarction, mostly STEMI, and showed important reductions. So if somebody's getting a lot of ischemia and they're not on a beta blocker, then a beta blocker might well help. Will a statin help? Yes, it will help, but it'll take years before the curves come apart. So don't feel that aspirin and statin is effective treatment of somebody who's acutely unwell with a coronary thrombosis. Much more important that they get these. Here's the European guidelines, and they're making a strong effort to knit together all the different possibilities and to risk assess patients. Where I think we're getting there with guidelines, but they are still difficult. They're complex. There's a lot of factors involved, and it's difficult to say, well, in this category do this, in this category do this, because there are all sorts of possibilities, and it's difficult to test all of the possibilities. And I put this slide in because in the randomized trials between aspirin and ticagrelor was better, so ticagrelor is up here, and there was no survival benefit, although there was a reduction in MI in patients randomized between clopidogrel and prasugrel. So prasugrel was here below ticagrelor, but then there's another randomized trial showing clopidogrel better than ticagrelor, and there's another randomized trial showing prasugrel better than ticagrelor. So it's very difficult to decide which is best in all circumstances. And I think it may be impossible to write a guideline for one size fits all. So that's why I think that the pragmatic guideline may win out. There should be some signed guidelines coming out at some stage. It was promised before the pandemic, but that hasn't been revisited recently. Here's one of my pragmatic guidelines again. This is not entirely serious, but it's a way of thinking about identifying patients who should be in the lab. Truth University acknowledged that a patient in possession of a GTN infusion, because they've got ongoing ischemic pain, must be in want of a stent. And that doesn't mean that they have to go absolutely immediately if it's 3:30 in the morning. The team have been out already doing left main stenting. Then the harm from waiting for a few hours with morphine and GTN is relatively low. But if it's early in the evening and you're starting a GTN infusion and the patient's in CCU, well, you should really be thinking about calling the interventionist and unblocking the occluded obtuse marginal, because some of them will go on to have late complications of a full thickness MI. And if a patient is unwell with COPD, of heart failure, sepsis, they're unlikely to have a coronary thrombosis as well. Or if they have a coronary thrombosis as well as all of these illnesses, then they'll be so sick, they'll almost certainly have ST elevation. And it'll be very clear that there's something else going on as well. And so checking troponin in these patients, yes, it seems to be hard not to do, but particularly if they're high bleeding risk, you really have to think carefully about giving them anticoagulation, antiplatelets. It's not likely to help, and there will be some associated harm as well. So here's my meme-based guideline. Clearly, my cultural references are not going to be universal, may not be recognised by junior medical staff, but this is one of the best bits of the Blues Brothers, when Aretha Franklin is telling Matt Guitar Murphy to think about the consequences of leaving their diner and going off with these hoodlums to play music. You better think about the consequences of your action. And it's a fantastic musical number, and it's very memorable. And if you've not watched the Blues Brothers, you could at least watch that scene, because if you better think what's the matter with the patient, and the dominant feature is ischemic pain, probably with a crescendo pattern, and their ECG is abnormal, and their patients at risk of ischemic heart disease, and they're not sick with something else, then anticoagulation and antiplatelets are going to help. And if the dominant feature is not ischemic pain and other things are happening, and they're at risk of troponin release because they've got atrial fibrillation and or hypertension and or renal disease and or heart failure, then anticoagulation is not likely to help. So that's what I think troponin is about. I'd be very pleased to answer questions. We've got a bit of time. We've got 11 minutes. So I'll see if I can stop sharing and see if there's any questions. Okay, no questions. I hope that's because it's so clear that we're never going to be invited to the acute medical unit to interpret a troponin result again in the future.
John, I don't know if you can see me. It's you and Pearson here. Just
Hi.
thought maybe easier just to ask a question and put it in the chat. And this is probably a simple question, but so obviously there's lots of people that we call you in and you say type 2 MI and then you walk away. Obviously, you know, what's clear from your presentation is you know, that is still a myocardial infarction. There is still potentially damage to the heart and wall, you know, disruption yes. to the function of the heart. Accepting the fact they don't need antiplatelets because they've had no plaque rupture, what would, and accepting the fact you treat the underlying cause and deal with the sepsis, you know, but they've obviously had a cardiac insult. What would we do in terms of their cardiac monitoring after the event, or in terms of any treatments that we might give them, given the fact that presumably some of them might just have narrow coronaries and therefore be at risk of subsequent type 1 MI?
That's right. Well, I mean, that's the key question, and I think at some stage in the future, hopefully, we'll know. I think if you've got coronary disease, there's no doubt that long-term aspirin is likely to help. Long-term statins are likely to help. Blood pressure control is very likely to help. There's probably benefit from individual agents up to 4 or perhaps 5, but clearly there's going to be some loss of effect. We can't just add every potential prognostic benefit up and expect that people are going to be immortal. So I think type 2 MI may not be may well not be a risk marker for patients who have additional benefit from intensification. They should be on a pragmatic secondary preventative therapy group and with the least side effects consistent with the best quality of life. The patients who are at highest vascular risk that are likely to get the most benefit from those, but at the same time, the highest vascular risk is the highest marker of vascular risk is age, and high risk is obviously not necessarily modifiable risk. So the answer to your question is they should be on the right tablets for patients who've got coronary disease. And what the analysis that I'd really like to see is that the patients who've had a type 2 MI, who've got known coronary disease, you know, a lot of the patients who've got heart failure presentations, for example, or previous CABG, how many of them who are not on the optimal secondary preventative care have been on the optimal secondary preventative care but have stopped it because they've had side effects or they've had problems with acute kidney injury from the combination of ACE inhibitor and spironolactone and diuretics. And I suspect that what is a modifiable risk will be obvious because it will be the patients who are younger who've got fewer comorbidities, and what's a non-modifiable risk will be fairly obvious as well because there'll be patients who are frail.
Okay, thank you.
Okay, thanks very much, everybody. I will I encourage you, if you've not signed up for climbing in ARCHIE on June the 4th, you can still sign up on the website. There's lots of nice hills to stand on and be part of a big event, raising money for the ARCHIE charity. And Grand Rounds continue next Thursday, and you can catch up on the recordings if there's a title that you find interesting. So bye all, and see you next time.